So imagine you're like on your emergency medicine rotation, right?
Yeah.
And a patient comes in and their serum sodium is just terrifyingly low.
Oh, yeah, like sitting at 110 or something.
Exactly,
Yeah.
110.
Yeah, okay.
And your first instinct, which is, the most logical thought in the world, is to just give them sodium. I mean, you just want to fix the number.
Right. Fix the red number on the screen.
Yeah. So you hang the IV fluids, the number climbs back up to normal, the patient seems okay, and you're feeling like a total hero. But then 3 days later, that exact same patient develops severe difficulty swallowing.
Which is terrifying.
It is. They're speech slurs. And by day 5, they were entirely paralyzed.
Yeah.
They're trapped in this condition called locked-in syndrome, completely conscious but unable to move a single muscle. And it's all because you fixed a number on a lab report, like a little too quickly.
Yeah, it's basically the absolute nightmare scenario in medicine. And it happens because treating sodium disorders requires just an entirely different level of clinical respect. You aren't just, adjusting some random electrolytes. You are literally manipulating the incredibly fragile osmotic balance of the human brain. So, welcome to today's deep dive. I'm putting on my clinical educator hat today because we are tackling sodium disorders and specifically hyponatremia.
And if you're listening to this right now, grinding through your PANCE or PAN-ROT prep, you know exactly how panic-inducing that red low sodium number can be.
Oh, for sure.
So our mission today is to bypass the rote memorization. We've got this whole stack of high-yield clinical flow charts, diagnostic algorithms, textbook excerpts, but we are not going to just read them to you.
No, nobody wants that.
Right, we're going to build the rock-solid clinical reasoning you need so that when you see a hyponatremia question, you don't guess, you just know.
Exactly. And by the end of this deep dive, we are hitting 3 specific learning objectives. First, we are going to master the absolute non-negotiable 3-step diagnostic algorithm, which is serum osmolality, volume status, and urine sodium.
Gotta know those 3.
You have to. Second, we'll use illness scripts to differentiate the underlying etiologies of hypotonic hyponatremia. And third, we will break down exactly when to use 3% hypertonic saline. And critically, how to avoid causing that catastrophic brain damage you just talked about.
So to keep this real, we've got an anchor patient we'll be tracking throughout the discussion. Picture a 72-year-old male brought into the ER by his daughter.
Okay, classic presentation.
Yeah, symptoms are pretty vague but concerning. He's got lethargy, some confusion, nausea, and muscle cramps. We pull a BMP, a basic metabolic panel, and his serum sodium comes back at 122 milliequivalents per liter.
Which is definitely low.
Very low. My gut instinct as a PA student is to, start hanging IV normal saline, but the literature just screams at us to hit the brakes.
Hitting the brakes is your absolute best clinical move here. Like the most common PANCE trap, and underline this in your brain, is assuming that a low sodium value on a lab report actually represents a true physiological lack of sodium in the blood.
Right. It can totally be a fake out.
Exactly. Step 1 is never treatment. Step 1 is always measuring the serum osmolality, or the S-osm, to see if the lab machine is just straight up lying to you.
Because what the machine reads and what the patient's cells are actually experiencing might be 2 completely different realities, right?
Precisely.
So if we check that serum osmolality and it comes back completely normal, which is like between 275 and 295 milliosmoles per kilogram, we're dealing with isotonic hyponatremia or pseudo-hyponatremia.
Yes, pseudo meaning false.
Right. I always picture this as like the lab equipment getting distracted by shiny objects.
Right.
If a patient has severe hyperproteinemia, say from multiple myeloma, or astronomically high triglycerides, those massive molecules physically take up space in the blood sample tube.
That physical space is the whole key to this concept. The lab machine measures the sodium concentration in the total volume of the plasma. But if a huge percentage of that volume is occupied by extra lipids or proteins, the machine calculates a lower concentration of sodium.
Because there's less water in that specific sample.
Exactly. But the actual water portion of the plasma where the sodium actually lives and where the cells interact with it has a perfectly normal concentration. The total body water and total body sodium are completely fine.
So you don't even treat the sodium?
Never. You treat the underlying lipid or protein issue. That is a massive board trap right there.
Okay. And then there's the other big fake out. I actually remember seeing a patient in diabetic ketoacidosis, and their sodium was sitting in the low 120s. But the attending told me it was an illusion because the serum osmolality was actually high, like over 295.
Right. That's hypertonic hyponatremia.
Yeah. And that attending was teaching me a super vital illness script. When blood sugar is in the 600s or 800s,
Yeah.
all that extra glucose acts as a powerful osmotic magnet, right?
It does. It stays in the extracellular space, and it literally drags free water out of the cells and into the blood.
So the sodium isn't actually depleted at all. It's just temporarily watered down by this massive influx of intracellular fluid. And once you give them insulin and the glucose drops, the water shifts back into the cells and the sodium concentration just magically returns to normal.
Which is exactly why the PANCE will test you on the correction formula. This is highly testable.
Oh man, the math.
It's not too bad. For every 100 milligrams per deciliter of glucose over normal, usually using 100 as the baseline, the serum sodium drops by about 1.6.
Okay, so if you fail to calculate that corrected sodium, you might look at the lab and inadvertently treat a sodium level that doesn't actually need fixing.
And then you end up pushing the patient into severe hyponatremia, which is a whole other disaster.
Yeah.
Oh, and bonus knowledge, IV mannitol, which is an osmotic diuretic, does the exact same thing as high glucose.
Good to know. Okay, let's pause here. Let's ask the listener to apply this.
Let's do it.
So, if you're listening, think about our 72-year-old anchor patient with the lethargy and muscle cramps. Let's say we pull his osmolality and it's 260. Based on what we just went over, what type of hyponatremia does he have, and what is our immediate next step?
Give it a second.
All right, so his osmolality is under 275, meaning it's low. This isn't a fake out. He has true hypotonic hyponatremia. His blood is genuinely dilute.
Spot on. Which forces us into step 2 and step 3 of the algorithm. We now know for a fact his body has too much water compared to sodium, but we have to figure out why.
Right, the underlying cause. Is he dehydrated? Is he overloaded with fluid?
Exactly. This is where we assess the extracellular fluid, or ECF, volume status.
And clinical volume assessment can be incredibly tricky in real life. I mean, you check their mucous membranes or skin turgor, you look for jugular venous distension or pitting edema, but the physical exam is super subjective.
It's notoriously unreliable. That's why the ultimate objective surrogate marker for volume status, basically the diary of what the kidney is experiencing, is the urine sodium.
The UNA. I love that. I like thinking of the urine sodium as the kidney's response to the crisis.
That's a great way to frame it. So let's walk through the 3 clinical volume buckets. Let's start with a patient who is clearly hypovolemic. They have low ECF.
Right, they've lost fluids. Maybe they've been vomiting for days and they look dry as a bone.
So if we check their urine sodium and it's remarkably low, meaning less than 20 milliequivalents per liter, what does that tell us?
That tells me the kidneys are working perfectly. They are acting exactly as they were designed to act.
Right, the body is severely dry.
Yeah, so the renin-angiotensin-aldosterone system, the RAAS, is firing on all cylinders. Aldosterone signals the kidneys to desperately reabsorb every single drop of sodium it can find. Because where sodium goes, water follows.
Exactly. And that's why the urine has virtually 0 sodium in it. The leak, the actual source of the fluid loss, has to be extrarenal.
Extrarenal loss. So we're talking severe gastrointestinal losses like massive diarrhea or vomiting, third spacing from severe acute pancreatitis, massive burns, maybe acute hemorrhage.
Yep. The body lost fluid outside the kidneys, and the kidneys are just trying to save the day.
But if the patient is hypovolemic and the urine sodium is high, like greater than 20, then the kidneys are the villain.
Bingo. The body is dry, yet the kidneys are stubbornly dumping sodium into the toilet.
Renal loss. The kidneys are inappropriately wasting sodium.
This is a massive, massive high-yield area for board exams, because the most common culprit you'll encounter in this bucket is diuretic use, specifically thiazide diuretics.
Thiazides are so tricky. Why is it that they cause hyponatremia way more often than loop diuretics like furosemide?
It basically comes down to where they work in the nephron. Thiazides block the sodium chloride cotransporter in the distal convoluted tubule.
Okay, the DPT.
Right, so they force sodium out into the urine, which gives you that high urine sodium. But because they do not disrupt the medullary concentration gradient in the loop of Henle, the kidneys can still respond to ADH and reabsorb free water.
Oh, wow. So a patient dumps the sodium but retains the free water.
Exactly, and the serum sodium just plummets.
That makes so much sense. It's not just that they lose the sodium, it's that the water retention mechanism remains totally intact.
You got it. Other causes in this renal loss bucket include things like adrenal insufficiency, where you completely lack aldosterone, or medications like ACE inhibitors.
Okay, so let's flip the script completely. We move to the hypervolemic bucket. The patient has a high ECF. They have massive pitting edema, ascites, crackles in their lungs. They are just drowning in total body fluid.
But here's the paradox. If we check their urine sodium, it might actually be low, like less than 20.
Which seems crazy. The body's overloaded, yet the kidneys are hoarding sodium as if the patient is dying of thirst in a desert.
This is all about the concept of effective circulating arterial volume. Think about severe decompensated heart failure or end-stage cirrhosis. In heart failure, the heart pump is just so weak that the blood isn't effectively stretching the baroreceptors in the carotid arteries.
And in cirrhosis, you get that massive vasodilation cooling blood in the splanching system, plus a lack of albumin lets fluid leak out into the tissues.
Exactly. So even though the patient's legs are swollen to twice their normal size, the actual arterial sensors feel completely empty.
So they scream at the kidneys, "Hey, we are hypovolemic!"
Yes, and the RAAS system activates aggressively, aldosterone spikes, and the kidneys pull back all the sodium, which tragically just pulls more water into the body and makes the edema significantly worse.
Just a vicious maladaptive cycle.
Yeah.
So that low urine sodium is the hallmark of those edematous states.
Right. But conversely, if the patient is hypervolemic but their urine sodium is high, greater than 28, the kidneys themselves are failing.
Like in acute or chronic renal failure.
Exactly. The nephrons simply cannot filter, they can't excrete the daily water load, and they lose the ability to regulate sodium excretion entirely. Everything just backs up.
Okay, we've tackled hypovolemic and hypervolemic, the dry and the flooded, but the most intellectually challenging bucket, and the one our anchor patient actually falls into, is the euvolemic bucket.
Or isovolemic.
Right. The patient's volume status on a physical exam looks completely normal. No severe dehydration, no pitting edema.
This is where truly understanding the physiology separates the rote memorizers from the diagnostic clinicians. In this euvolemic state, we again look at the urine. If the urine sodium is less than 20 and the urine osmolality is very low, less than 100, we have a really bizarre situation.
It means the patient is either taking in massive amounts of water or their diet is completely devoid of solute.
Right. The classic board scenarios here are primary polydipsia, like a psychiatric patient drinking dangerous volumes of water, or the tea and toast syndrome seen in elderly patients, or beer podomania in chronic alcoholism.
The tea and toast one always tripped me up. Like, if an elderly patient is just eating plain toast and drinking tea, sure, they aren't taking in any sodium. But why does that cause their body to actually hold on to water and drop their serum sodium? Shouldn't they just pee out the water they drink?
It comes down to the obligatory solute loss mechanism. To excrete free water, your kidneys physically require a certain amount of solute.
Like urea from protein.
Exactly, urea or electrolytes like sodium. The kidneys need those solutes to drag that free water into the urine. If a patient is surviving purely on carbohydrates and alcohol, their solute intake is essentially zero.
So they literally don't have the biological tools to make dilute urine.
Exactly. Their solute intake is so profoundly low that it just paralyzes the kidney's ability to excrete water. Even if they only drink a totally normal amount of water, they physically cannot pee it out because there's no solute to carry it. The water just backs up into the blood, diluting the sodium.
That is wild. The kidneys are fully functional, they just lack the raw materials to do the job.
Yeah. But what if our euvolemic patient has a high urine sodium, like greater than 20?
Then you are staring down the barrel of the most common cause of euvolemic hyponatremia, SIADH, syndrome of inappropriate antidiuretic hormone. Let's pause and apply this directly to our 72-year-old anchor patient.
Okay, let's hear it.
So we know his sodium is 122. His exam shows moist mucous membranes, clear lungs, no edema. He's perfectly euvolemic. We check his urine. His urine sodium comes back at 45, which is well over 20.
So his body is actively dumping sodium.
Right. And his urine osmolality is 400, reflecting highly concentrated urine.
Think about what that actually means on a cellular level. His body is releasing ADH when there is absolutely no physiological reason to do so. ADH goes straight to the collecting ducts in the kidneys, inserts aquaporin channels, and drags pure free water back into the bloodstream.
So that free water dilutes the blood, plunging his serum sodium down to 122. And because all that water was just ripped out of the urine gets highly concentrated, which is why that urine osmolality is so high.
The diagnosis is SIADH. You've successfully navigated the entire diagnostic algorithm.
But diagnosing it is only half the battle, right? Step 3 is management. We need to treat his 122 sodium without triggering that horror story we opened the show with.
Yes. The osmotic demyelination syndrome trap, or ODS. The literature is aggressively clear on this. With very few exceptions for life-threatening emergencies, you must never correct serum sodium faster than 0.5 milliequivalents per liter per hour.
Which is so slow. A typical safe goal is raising the sodium by only 4 to 6 milliequivalents over an entire 24-hour period. It feels so counterintuitive to move that slowly when patients' labs look that dangerous.
It feels completely wrong until you understand how the brain survives chronic hyponatremia. See, when sodium drops slowly over several days, the blood becomes dilute. Osmosis dictates that water wants to rush from the dilute blood into the more concentrated brain cells.
Which would cause the brain to swell and herniate.
Right. So to prevent that massive fatal brain swelling, the brain cells adapt. They actively dump out their own internal osmolase, things like amino acids and an unisotyl, into the blood.
They intentionally dilute themselves to match the blood.
They do. They achieve a new, incredibly fragile equilibrium. Now, if you suddenly panic and pump the patient full of IV sodium, reversing that low number in just a few hours, the blood suddenly becomes relatively hypertonic compared to those newly adapted brain cells.
Oh man, so the osmotic gradient reverses violently. Water gets rapidly sucked out of the brain cells to balance the newly salty blood, and the brain cells just shrink and dehydrate.
And that rapid shrinking physically tears apart the myelin sheath around the neurons. Classically, this happens in the pons of the brainstem, which is why it used to be called central pontine myelinolysis.
The truly terrifying clinical reality of ODS is the delayed onset. Like, you fix the sodium, the patient seems perfectly fine for 2 to 6 days.
The calm before the storm.
Exactly. And then the demyelination catches up. The dysarthria starts. The paralysis sets in. And the damage is often irreversible.
The algorithms in our sources actually include a rescue protocol for this, which is fascinating. If you're tracking the labs and realize you've accidentally overcorrected the sodium too quickly, you don't just watch and pray.
Right, you use a DDAVP clamp.
Exactly. You actively administer synthetic ADH to force the kidneys to stop dumping water, and you might even hang an IV bag of D5W, which is basically pure free water, to urgently drop the serum sodium back down into those safe neurological limits.
Actively giving free water to a hyponatremic patient to save their brain is some serious next-level medicine.
It really highlights just how dangerous overcorrection is. So how do we treat these different volume buckets safely? It depends entirely on the etiology we uncovered.
Right, so for hypovolemic patients, they're dry, so they need volume. You give isotonic fluids, like 0.9% normal saline. As their volume restores, the baroreceptors quiet down, the RAS shuts off, ADH shuts off, and the kidneys will naturally just correct the sodium imbalance.
And for hypervolemic patients, like our heart failure cases, it's the exact opposite. Volume removal. You restrict sodium intake and you use diuretics to pull the fluid off.
And for isovolemic states, like our anchor patient with SIADH.
The primary treatment is fluid restriction, usually less than a liter a day. You stop adding to the free water pool, and you aggressively hunt down the underlying cause of the SIADH.
Which could be a small cell lung cancer, a central nervous system infection, or a medication side effect.
Exactly, but let me throw a curveball at you.
Okay, I'm ready.
What if a patient is profoundly hypervolemic, massive heart failure, completely overloaded with fluid, but their sodium suddenly drops to 118 and they start having active grand mal seizures in the ER? We know they need fluid restriction, but they are seizing right now.
This is a critical PANCE pearl. The moment a patient develops severe neurological symptoms, meaning they're obtunded, comatose, actively seizing, or in respiratory arrest, or if the hyponatremia is known to be acute, meaning it developed in less than 48 hours, you throw the volume status entirely out the window.
You ignore the fluid overload completely and treat the immediate threat of brain herniation.
You give IV hypertonic 3% saline, regardless of the underlying etiology. The goal isn't to bring the sodium all the way back to 140.
No, definitely not.
The goal is to acutely raise the sodium by just a few milliequivalents, usually just 4 to 6. Just enough to pull water out of the swelling brain tissue and stop the seizures.
Right. And the standard protocol is a 100 ml IV bolus of 3% saline over 10 to 60 minutes, which can be repeated if the severe symptoms persist.
So 3% saline is strictly heavy artillery. Returning to our 72-year-old anchor patient, his sodium is 122. He has lethargy, some confusion, and nausea. But he is awake, protecting his airway, and absolutely not seizing.
Which means we keep the heavy artillery locked away. We diagnosed his SIADH, and we treat him conservatively with fluid restriction. No 3% saline needed.
We covered a massive amount of clinical ground today. Let's lock it in with some rapid-fire key takeaways. Number 1, always start with serum osmolality. Do not get tricked by pseudohyponatremia from lipids or hypertonic shifts from massive hypoglycemia.
Number 2, use your extracellular fluid volume status and the urine sodium to build your illness script. Remember, a urine sodium under 20 means the kidneys are desperately holding on tight. Over 20 means they are inappropriately letting it go.
And number 3, respect the brain. Correct slowly, 4 to 6 milliequivalents a day to avoid osmotic demyelination syndrome. Only break out the 3% saline if they're seizing or comatose.
Okay, let me throw a couple rapid-fire board-style questions at you to see how this clinical reasoning holds up under pressure. Question 1. You're on your internal medicine rotation. A patient's chart shows a serum sodium of 126, but their blood glucose is 650. What is your immediate next move?
I am not touching that sodium level. The high glucose is pulling water out of the intracellular space, diluting the blood. I need to calculate the corrected sodium to see what the actual value is, and then focus my treatment entirely on resolving the hyperglycemia with insulin and fluids.
Perfect application of the formula. Okay, question 2. A patient with a known history of severe, poorly controlled heart failure comes in struggling to breathe with massive peripheral edema. Labs show a serum sodium of 128. What do you expect their urine sodium to be?
Well, they're hypervolemic, overloaded with total body water, but their failing heart means their effective circulating volume is terrible. Their kidneys literally think they're bleeding to death. The RAAS system is activated, so the kidneys are aggressively reabsorbing sodium. So I expect the urine sodium to be less than 20.
Excellent. Final question. A patient with chronic hyponatremia is admitted to the ICU. The team gets aggressive with IV fluids, and the sodium rises by 18 milliequivalents in the first 24 hours. On day 4, the patient develops severe dysarthria and quadriparesis. What just happened?
We triggered osmotic demyelination syndrome. The overly rapid correction made the blood relatively hypertonic. Water was rapidly sucked out of the brain cells that had already adapted to the low sodium, causing them to shrink and destroying the myelin in the brainstem.
The clinical reasoning is completely locked in. I want to leave you with one final thought, something for you to chew on during your next clinical shift. Next time you're reviewing labs and you see a quote-unquote normal sodium level of a 140, take a look at their glucose. If their glucose is 800 but their sodium looks totally normal, what is that normal number actually masking?
Wow. If the glucose is pulling that much water into the blood, diluting it, and this sodium still reading 140 on, their actual corrected sodium must be dangerously high.
Keep thinking like a clinical detective. Sometimes the most dangerous number on the lab report isn't the one flashing red, it's the one that looks perfectly fine, hiding a massive derangement underneath.
Never trust a normal number without context. Thanks for joining us on this deep dive. Keep grinding on those illness scripts, trust your clinical reasoning, and we'll see you next time.